recorder. Let's turn the light off or light down. It's his fault. Either the really tall people or the really short people. I don't know. Sorry for not having all the minutes and all the stuff organized, but you know, we're still looking for a ship for you. As you all know, Mira left and moved to Arizona. So we're actively looking. And hopefully have that position filled before the next meeting. We sent out late copies of the minutes. Because what I'd like to do is you probably haven't had a chance to read them, have you? You have, nodding heads. Good. You passed them out?
Because I sent them late, I made copies to read.
So we could ask for a motion to approve the minutes. Okay, do we have a second?
I second.
Thank you, Tara. All in favor, please signify by saying aye.
Aye.
Any opposed? Same sign. Since we're now, we have the ladies here, why don't we all introduce ourselves once again? It's always a good thing to do. We have new faces. Make sure everybody knows everybody. So,
Perfect.
sorry?
Sheree Morgan, long-term care at Lake County Senior Center.
Larry Coulter, long-term care and senior center board member.
Andrea Wishart, Senior Center. Noni Moss, Senior Navigator at the Senior Center.
Mindy Bentley, outreach hygienist with Advantage Dental.
Nora Zimmerman, EOCCO / Greater Oregon Behavioral Health, Inc.
Beth Hadley, Public Health. Cecilia Montgomery, Hospital Auxiliary.
Tara Jones, social worker and specialty clinic.
John Adams, Eastern Oregon Healthy Living Alliance in Gobi.
Diane Clay, Hospital Auxiliary. An interested person. Not interesting, just interested.
Oh, sure.
Yeah.
Jen Mantle with the hospital.
I'm Charlie Quick for all of you that don't know.
Paul McGinnis, Greater Oregon Behavioral Health and Eastern Oregon Coordinated Care Organization.
Jimmy Hall, Lake County Examiner newspaper.
Thank you. I don't think we have any, do we have anybody on the phone? No.
Yeah.
Yes.
This is Jamie Davis with the OSU Extension Office.
Hi, Jamie.
Calling in.
Sorry about that. Anyone else?
No, I think just Amy.
Marvelous. Glad you're here, Jamie. Thank you, everyone, for coming. So we're kind of a couple items we want to talk about. First, we want to have Paul talk about the RAC annual report.
Okay, this is a report from the Regional Community Advisory Council. The chairperson, Charlie in this case, and a county commissioner or a designee are the ones who represent Lake on this group, and at their meeting on June 27th, they approved the report to go to the EOCCO. I don't know that it's been distributed here, though. I see it on the screen, but I don't think it did go out. But I'll just summarize some of the experiences that other community advisory councils have had, and it will either resonate well with your experiences here, or it may seem a bit off kilter a little bit, but it's trying to collectively say, here's what the community advisory councils think, and moving forward. I think that the key, Jen, if you'll go to it so that people can follow along, we'll just go to the recommendations, which is page 11. You'll get this report, but Carissa Bishop and Ari Wagner with Gobi staff interviewed people as part of this process overall to get their feelings on certain items. And I think that most of the community advisory councils feel overall, I mean, if this was a State of the Union address, I would say, you know, that the CACS is good. I didn't say, you know, excellent or whatever, but it's good. We're solid, and we're better understanding what we're trying to accomplish. And I think that that's a key for us overall. For you, it's kind of a little transition from, you know, our discussions that we've had at the end of meetings that haven't really kind of brought the fruition that people were looking at, which was, you know, what should we call ourselves? Because you had this program called the Community Health Improvement Partnership, and then all of a sudden you got, you know, the Community Advisory Council activities kind of intertwined with it. And there's a couple of places that were like that. You know, it kind of changed the focus a little bit, obviously, because some money comes with Community Advisory Council. The Community Health Improvement Partnership Program is much broader in focus, whereas the Community Advisory Council technically is focused on the 1 in 4 people that are part of the Medicaid program here in Lake County. So there's a little bit of change there in terms of understanding how things are going. But now we had introduced some things like incentive measures, and people have known, what is this stuff and what does it mean? And you know, we've had a year of dealing with it. We've seen some money flow, and I think overall people are having a better understanding. In October, we hope to update the primer that we delivered here last August, which is kind of a, you know, an EOCCO 101 that will update what's happened and also share what's going on in the future. So at the top of the page, we talk about the incentive funds and transformation grants. I believe at the last meeting, we let you all know that the EOCCO met 13 of the 17 incentive measures, many just by the skin of our teeth, and we missed the colorectal cancer screening incentive measure by 10 people.
Oh.
10 people. So, you know, but again, if you remember, the bar is rising. Every year they withhold more money and our benchmarks are higher. The RCAC wants to encourage the board, so this is what you're seeing here, is that incentive funds continue to be shared with the LCACs and that the transformation grants be continued. There is a subcommittee of the board of directors that is looking at how to invest that $10.2 million right now. And so they get this information likely to continue there. But you'll see a little bit down that it's, go ahead.
If I could interrupt just one second. When we keep talking, as we struggle with our name, we quit struggling because we're still going to be a CHIP program. When John was acting as our CHIP coordinator, one of the things we did was, and John did, was try to raise money outside of the CCO dollars. So did Mira. So we want to keep in mind that a lot of what this talks about is 1/4, small percent, of our population. That those incentive dollars, those incentive measures, and the dollars affiliated with that is designed toward 1/4 of our population. It does not deal with our seniors. Now, a lot of our activities do. And so we want to continue to find monies that support all of our Lake County. But that, as we
I may not have been clear, but I hope that was my intent to say what's right.
I hope everybody's hearing that we're looking for multiple different ways to help improve our community's health. And it's just one source. But this is a big source, you know, $10 million to deal with the 25% of our population in Eastern Oregon. That's a lot of money, but there's a lot of people. We got 75% of the other people to deal with. Okay, that's what
You bet. So one of the things that we've heard from CAC members is when it talks about the incentive measures and the transformation grants that are saying target on the incentive measures, that the people would like to try to allow the EOCCO, and really it's Oregon Health Sciences University's Evidence-Based Policy Center that's reviewing the grants, because we give that to a third party to look at in terms of the review of it and say, you know, they're saying, well, how are you gonna measure this specifically? And if the idea is, you guys are doing prevention work, and we need to be able to go more upstream, where funding, for example, for an exercise program, how can you target that specifically to an incentive measure unless you grab somebody with high blood pressure or diabetes and put them into that program, whereas we want to make it available to the community, or funding the food bank. We've had people talk about that, whereas nutrition and physical activity really lead to better health care in terms of being able to control diabetes and hypertension. But, you know, when money's involved, it's like, okay, how are you specifically doing that around these incentive measures? And I think the CACs want a little flexibility, and I agree. So we put that in the report. Whether it's goes forward, we'll see. Data collection and the incentive funds, again, it kind of relates to that, to be able to not be so specific about if I did X, then Y occurred, and make the collections a little bit more simple. In membership changes and orientation, if you could scroll down. There's
I do apologize for being late, and I have to leave a little bit early.
Commissioner Kestner. He's coming right in on time.
Staying consistent.
Well, we were talking about the primer here, and also in 2016, the primer, just making sure that we have a good understanding of how the CCO can serve their roles better. But hopefully, one of the things that we're recommending is when we do the primer, and Ken comes to, Commissioner Kestner comes to, all right, Ken comes to the meetings here when he's able to do so. But not all of our CACs have a board member present at that meeting.
We are very fortunate.
You know, so you'll see
The limited time that we get of our commissioner and board member, we appreciate all the time we get.
Right. So we're just suggesting.
Charlie attends almost everything because he has the knowledge and capabilities.
It's getting thick, Brad.
So anyway, what you'll see there is we're recommending that a board member come when the primer is presented, so that at least the CAC can know who might be their representative on the board, whether it's a hospital leader or an owner or whoever. But that's what we want to have there. We still have problems at the bottom. This is a follow through from last year's report. Technically, there are, I mean, Nora and I introduce ourselves as Eastern Oregon Coordinated Care Organization, but there's nobody that actually carries a business card that says that they work for the EOCCO. You're either an Advantage employee, maybe over there, right? They're our dental care organization. You are either that or a GOBE, Greater Oregon Behavioral Health employee, or you're a MODA employee on the physical health, mental health side. We're finally starting to get some data integrated, but you know, communities will ask for data, and it's hard to get sometimes from the other organizations, and we're just pointing out that it's still an issue. The top of the next page is a recommendation that actually came specifically from Ken, and that's a lack of our media attention. Jimmy's the only one that comes to a meeting out of all the 12 LCACs that we actually have press coverage. You know, where a local story is written, and he does it and does the initiative on his own about what's going on there. And if he wanted to, he could look at the interesting discussions that we have here and go follow up and write a separate story about a transportation program or the food bank when the truck came and delivered all the fresh foods, that kind of stuff. All of our LCACs are doing interesting things, and the broader community doesn't really know about it. And so we're just recommending that maybe the CCO needs to invest in somebody who can generate press releases and or get dollars available to do paid media. around some of these incentive measures for the benefit of everybody. I mean, if you were driving by and it said a billboard, 50 to 75, you need a colon cancer screening. Contact your local provider, or, you know, we need children for X, Y, or Z to be able to invest in some of that. Ken, any additional comments?
Yeah, just both as what the group is doing, and as you touched on at the end, everything from dental, children and dental, just a little information. So the parents will say, or the kids will say, Mom, see that? Colon, kind of a S subject, but
Yeah.
get it out there.
Yeah.
Heart disease, obesity, just get a little spurt out there, because people don't think about things like that. They're just busy getting on the tractor and farming all day. So just submit your thoughts constantly, because we all know what this subject is, and 30 of us out of 7,800 people is a very small percentage. We had to reach out to the homestead and kids.
And that once again goes to show how fortunate we are in Lake County that we have media that's interested. And that is really representing our community with lots of information. So we appreciate you.
Yeah, just a little story on different topics.
I remember when I was with the CHIP program, there was a lot of talk about just wanting to do more around outreach and health education, health promotion, and we talked about, you know, every county, every CAC, they're all saying the same things as far as you know, outreach to the community, more health education, more health promotion. And so part of this is, you know, how can we work together and get consistent messages out there throughout the region around, you know, things that the EOCCO cares about around, you know, diabetes and colon cancer and different things. And so I think that's kind of part of the concept behind this too.
Yep, thank you, John. The next one is an internal issue, and it's kind of a, I don't want to say, the more money that comes to this group, the more our charter needs to be revised so that we understand, you know, who is able to vote on things and who is not. I mean, we welcome everybody at the meeting, but there are certain members who are appointed by the county court here to actually be LCAC members. So as money is coming in, we kind of created some better rules for that. And Regional Community Advisory Council approved those rules, but the EOCCO Board of Directors has not approved them. And we're just asking, okay, if you don't want to deal with that, let's just let the Regional Community Advisory Council approve the LCAC charters, because their charge is to make sure that all of the local community advisory councils are following suit. So that's what that's about.
And a little additive on the membership. When we first started, I was getting lots of, John helped, a lot of conversations. As people move on, exit, I haven't had a chance to keep them. John did while he was in there, but John's moved on too. And Mara was trying to get them, had a few applications, but then she departed. So we have a little house cleaning as far as getting a current listing.
We'll get that. That'll be a charge for us.
And then lastly, what Charlie talked about was, you know, just a reminder to our board of directors that it's not just all about the Medicaid population for the community groups that we're working with. And sometimes when you're focused on that population, you forget that communities are interested in community health and not just one segment of the population. So
Our next presentation, you'll hear about how the district is focused on our entire population. We'll talk a little bit more about that.
And a tidbit on what just being said, the audit community, but right now it's the Medicaid. Well, envision the non-Medicaid, if you get them on the right track today, they will be the Medicaid tomorrow.
Anyway, if we could distribute this with minutes, I would encourage you look at the narrative, where you may see quotes from other members, but you know, essentially, people are saying to the EOCCO board, we appreciate the financial support through the transformation grants and the incentive measures and hope that they continue. That there is health integration actually taking place between public health, primary care, hospitals, oral health, and mental health. It may not be that perfect coordinated care organization that everybody envisioned at first, but we're moving in the right direction there. There is significant emphasis on prevention, and that there's some stories about some individual lives that have been changed because of some of the stuff that we've done. So I'd encourage that narrative to be read. That's it for me, Charlie.
Thank you. Thank you, Paul. Yeah, we'll get this out to you. I was kind of waiting till the board had approved it before sending it out, but no sense waiting.
Which board approves? The EOCCO board? They just get it. They don't have to deal with it at all. We just have to submit an annual report, which is what we
So,
do.
no sense in us waiting. We'll get that out the next day, or either today or tomorrow.
The RCAC, the regional community advisory council did approve it, so.
Well, that was just 2 weeks ago, so we're not too far behind.
No.
Thank God for that, otherwise we. So, one of the things that we've done is invited Juanita Trinko here, who is our clinics director, to talk a little bit about a program that not many of you have heard of, and that's called a patient-centered primary care home. And so, this is something that has been a driver for the state when it established the CCO. In fact, then Governor Kitzhaber came out with the position that he wanted by, I forget the date, maybe it was 2018, 100% of all state paid for health services. So that includes Medicaid, that includes all of the state employees, and anybody that has insurance paid for by the state, all would be enrolled in a patient-centered primary care home. Most of the large counties on the I-5 corridor, of course, have patient-centered primary care homes. We're one of the few that doesn't, but we will very shortly. So Juanita, if you'd like to talk a little bit about what we're doing.
Just a little bit on the introduction there, though, Charlie. Well, it is an incentive measure for the Eastern Oregon Coordinated Care Organization, how many patients are assigned to patient-centered primary care homes. So there is encouragement for that. Part of the money that was held back goes back to patient-centered primary care homes in the form of a per member per month payment. Right now there's a 1, 2, or 3 tier system. If you're a tier 3 patient-centered primary care home, you would get $15 per member per month for a person assigned to your clinic. So if there were 1,000 patients in your clinic, every month the EOCCO sends a check to that clinic for $15,000 in order for them to pay for the services that Juanita is going to describe, because it's not just the regular doctor visit, it's a transformation of primary care. And this year, we were at 73.5% was the final number for 2015. And it is supposed to be at 100%, I think, at 2018 or something like that. But when Juanita pushes the button in the tests, our percentage is going to go up strong.
Question?
Paul, just curious what that percentage was for, that 73% that you mentioned?
Region-wide?
That was our final rate for EOCCO wide.
And
72%?
73.5%.
Okay, thank
just
you.
for a little clarification for all of us who are from Arkansas, a little clarification on the term home. That's when I think of home, that's when I go out to work.
Yeah, these guys over here said that as soon as they came up with a name, but it was created by the National Committee on Quality Assurance, NCQA, and it was just kind of adopted here. But yeah, it's confusing, and
It's a primary care provider.
It's a clinic that you'd consider my home for primary care.
But you know that that's something especially in urban settings. Patient-centered primary care home is not a new concept. It's been something that has been worked on in large communities for a long time. And one of the things we don't struggle with quite as much, because we don't have as many specialists readily available, but in an urban setting, where you have large numbers of specialties, lots of people don't know how to access care. They don't know when to go to a rheumatologist, when to go to a nephrologist. A lot of people don't even know what a nephrologist is, or a whatever specialist. And so by viewing it as the primary care is 4 specialties. Does everybody know what the 4 specialties are? Family medicine, internal medicine, pediatrics, and OBGYN. Those are the 4 classic concepts of primary care. So those are when you talk about a home, that's where your core base, and from there, that practitioner is going to direct your care, kind of like the orchestra leader of the band, and directing you to all the specialties. That's what a home concept is.
Well, at Lake Health Clinic, we've been working really hard to meet the NCQA standards so we can attest for certification. And it's a way of telling our patients and staff and ourselves, and really holding ourselves accountable of things that we say we're going to do and prove that we're going to do it. It's really focused on involving the patient in their care and team-based care, and really trying to engage patients to improve their overall quality of life. It's not just about Mrs. Jones needs hypertensive medicine, and that's why she's coming in, and she comes in every 90 days to get her meds. Well, Mrs. Jones, what can we do to help you a little bit? Are there other things that are creating this problem with your hypertension? Maybe it's diet, maybe it's stress. So we're really kind of looking at all of that, the patient as a whole, and all of the team working together. So the doctors with the nurses, with the front office, with other specialties, and really focusing on this patient, and then working with the patient and their family members, and ensuring that the overall needs are met, making sure that we have access and availability, and sometimes just somebody for that patient to call and talk to. So really focusing on those factors, and then looking at things such as chronic diseases, hypertension, diabetes, obesity, those things, and what can we do beyond medication, and how do we engage the patient to make those critical changes in their lives that improves the quality of their life, that improves their health and well-being beyond just your normal medical care. It's a lot of work, and we're really excited that we're able to attest. It's a continuous effort, so it's not we attest one time and we say we've done it and we've met it. This is, we're going to attest, and we're going to tell you that we feel that we're ready, and we've put in a lot of policies and procedures and workflows, and we've built our EHR system to match and meet these criteria. But the other thing is that we will show NCQA that we continue to do so, and that we're going to do things like look at our population and say, well, we started here, and and by doing these things and engaging these patients, where is this same group of patients? And look at it and show ourselves, and we'll show our patients, and really, hopefully, what we want to accomplish is get everybody together and involved in their care. So that's our goal, and that's what we're going to do. So I have worked with a couple of other clinics that have implemented PCMH, and I will tell you, the most wonderful thing to see from a nursing standpoint is when you see your patients that come in and have these out-of-control A1Cs, or maybe they're not getting their meds, and maybe they're not getting their meds because they can't afford them, and maybe they don't want to tell you that. So it's really trying to figure out those things. What are the barriers? And then you look at that same group of patients in 6 months, in a year, and because you're following them and helping them, and you know everything that's kind of going on, their improvements in their health and their life. And then when you hear them say, I don't have to take these 3 medicines now, I'm down to 1, and you're following up, and you find the patient becoming engaged in their care. it's it's a transformation, it's a lot of work, but it really is worth it in the end when you see your patients' lives change because of this. So that's where we're at.
Couple comments. Well, just to clarify again on the difference. Juanita and this clinic are changing their care for everybody, not just Medicaid patients. Medicaid, through the CCO, will reimburse them and recognize the work that it takes to get this done. But private payers are doing the same, including the Summit and Synergy plans, which are part of MODA. Aetna will pay a little bit, and we're guessing that at some point Medicare is going to come in. The other thing is that I want to recognize is there's only a handful of clinics in the state that are going to meet the National Committee for Quality Assurance standards for a patient-centered primary care home, which is what Juanita and the group here are going after. Oregon's rules for becoming a patient-centered primary care home, the bar is a little lower. So you have high achievers, and all of these services are going to be provided to all patients. I mean, it's not going to be any different for Medicare, Medicaid, or private pay. It's going to be at the standard that you guys can be proud of.
After all, we're treating our entire community.
Yep.
Not just one segment of the community.
Well, and as caregivers, we don't look at patients as to their insurance. We're looking at the patient. We're treating the patient based on the patient's needs, not necessarily what their insurance is. We don't look at that. So absolutely, we want to. It's a great way to transform care and improve people's lives and look at everybody, not just one carrier or another.
Excellent. Are there any questions? Oh, yes.
I just had a quick question. I don't typically work with the PCPH side of things, but I'm curious how this work is going to be accomplished.
Well, it started out, we purchased our EHR system. We took the EHR system and we took the standards, so NCQA.
Electronic health record.
Sorry. So we took our electronic health record and we looked at our NCQA standards, and they're broke down about access and availability and population management. So there's a host of requirements. And we took that and we built our EHR to meet that. So now we've trained our staff on how we're going to meet these measures. We've done things like we have a patient portal where patients can send an email to their provider essentially any time or day. We've trained people on to become a health coach so they can help patients become more engaged. We've hired additional staff because that takes a lot more work. It's not just a matter of collecting your vitals and taking your history. It's a matter of collecting your vitals, taking your history, following up, getting your labs, and making sure you get your labs, making sure that you get to your referral provider. Not only are you getting to your referral provider, are we getting those results back? Making sure that we have all of that, making sure we communicate with the patients, proactively looking at care, look at more preventative measures. So we did all of those things and we built all of that in. We've looked at our clinic and looked at our quality assurance in itself, and we know, and we've engaged the providers to do so and look at their QI and say, oh wow, I want to do better on those things. So it's really a matter of everybody has to be involved and everybody has to be on the same page.
I think a perfect example, this morning, Andrea and I were in a meeting to talk about one of the factors that really impacts healthcare is access. So that means access, not just getting in to see their doctor or their practitioner, but that means getting to the clinic. If a lot of people can't get to the doctor's office, that means they can't be seen at all. They may not have transportation, they may not have a way to get to the doctor. So we talked about some of the barriers that we have here in Lake County. It may not seem like a big barrier here in Lakeview, but you know, if you're different parts of the county, it is a different issue, as we all know. So trying to figure out some of those issues will come up through this program. If there are any questions, I know that we have some guests here with John and others. Maybe what we ought to do is have everyone talk about some of the issues that they're focused on and give an update. Jamie, do you want to talk while you're on the phone first, and then we'll move along? Jamie, you still there?
I sure am, thank you. Yes. So as far as issues or things we're working on that are relevant to the group is we are moving forward with the Youth Health Advocate Program that will be training youth from Lakeview and North Lake to be peer leaders and teach 4 health-related topics this fall, monthly topics in Lakeview and the North Lake schools. And the end goal is not only to increase health knowledge around 4 different topics, but to have youth go to see their physician for a child appointment.
Awesome. Thank you. That will be a huge program and real big benefit. And of course, you know, we've got to make sure that our practitioners are able to accept all those people that come. Because it's one thing to say we want to see them, it's another thing to be able to see them. So, good. Thank you, James. John, do you want to say anything?
I just had a quick question. James, is this one of the transformation grant or any
It is.
Yeah.
Oh, yes.
Transformation group. And also,
Both.
you might have to remember
Thanks, Charlie. Just wanted to give a quick update on the Eastern Oregon Healthy Living Alliance. And so Mira was our board member, and I believe she was giving everyone regular updates on what we've been up to. And just to give just a real quick background, so the Eastern Oregon Healthy Living Alliance is a new nonprofit that was formed by the Regional Community Advisory Council to improve community health in Eastern Oregon by helping to provide strategies within the Regional Community Health Improvement Plan. So similar to Lake County, the RCAC has an R-CHIP, and many of the same issues that were prioritized here in Lake County are also prioritized regionally. So oral health, mental health, and some of these issues. And so just to give you an update on some of the our activities related to these programs. So first, for oral health is a school-based oral health program. Again, similar to Lake County, we're providing this program regionally. We receive grant funding through the EOCCO, through a transformation grant, and through the Oregon Children's Dental Health Initiative, which is the same grant that funds the Lake County program through the CHIP program here. And so our goal is to be able to provide fluoride varnish, dental screenings, classroom education, and follow-up for kids identified with urgent dental care needs to kids in targeted schools in Eastern Oregon. And through the grant funding, we're able to serve up to 23 schools in the region. We're targeting schools that have a 40% or above free and reduced lunch rate, so schools that are have a student population with low income levels. And so we've been able to, since we started the program, we've been able to get the interest from a number of schools to participate, including 2 in Baker County, 5 in Malheur County, 12 in Harney County. So we were working with the Wallowa County Community Advisory Council around supporting their program, because they kind of got pieces of a program off the ground, and they were looking for us to kind of work with them and to support them. So we just heard back that the schools are not interested in expanding. So they were doing previously grades K through 3, or just I think maybe first through third grade, and they're not interested in expanding through 8th grade. So we will our program will not be working with Wallowa County. We're now targeting some schools in Grant County. We've been able to hire a program coordinator to help coordinate this program. She's actually here from Lakeview, and we grabbed her from the school district. She's Alana Chamalak, and we're really excited to have her on board. And the other thing is so the classroom presentation piece that we're doing, we're going to be using this tool called a learning lab, and it has various stations set up so that the kids kind of walk through and they learn different aspects of oral hygiene and oral health. So one thing we're doing first is we're fundraising to raise money for the Learning Lab. It costs about $10,000, and so if we're in 4 counties, our goal is to raise about $2,500 from each county to be able to purchase that piece of equipment. And then we're also looking for volunteers in those 4 counties to help us to provide the Learning Lab during our service dates. And then finally, we've been working with the community advisory councils in those counties to help us kind of identify businesses and corporations and wealthy individuals that we might want to reach out to and approach about sponsoring the Learning Lab in their county. So the mental health first aid program, so again, this is one of the strategies of the Lake County CHIP, and I know that we did get transformation grant funding to do mental health first aid here, and Lake County Mental Health was leading on that. Unfortunately, because of just kind of staffing issues at Lake County Mental Health, they weren't able to implement that program here, and so they had to give back that funding, and so the funding that we have is we're able to provide mental health first aid throughout the region. We received a grant through the Oregon Health Authority that helps us do 12 mental health first aid trainings. So we do want to do one here in Lake County, and we've reached out to the schools and talked to Superintendent Will Cahill, and he's interested in providing the training to the teachers. The colon cancer screening focus groups. So again, this is a project that we did here in Lake County, where we use incentive metric funding to try to improve colon cancer screening rates in the county, and we had pretty low success here. 4 other counties in Eastern Oregon also used their incentive metric funding to try to increase the screening rates, and some counties had some fair success, and other counties not so much. And this is one of those areas where the target population is folks 50 to 75, and so this does reach into that senior population where this can benefit the senior population. So we did focus groups in the 5 counties that use their incentive metrics to impact the colon cancer screening rates. So Lake County, Harney County, Sherman, Wheeler, and Gillum. And the focus groups went well. Paul did an excellent job of facilitating. Thanks to the Senior Center for helping us to do the focus group at your place, and then also just to help us around outreach. So our goal was to get 10 to 12 folks at each of the focus groups, and we were able to do that in every county except in Sherman County, where we got 9. So right now we've transcribed the recordings from each of the meetings, and so now we're taking that and looking at what were the results. So we'd like to have a final report by the middle of August, and we can share that with you guys when we have that.
We're looking for September is when you actually have that available.
Yes, before we be able to share that, yeah.
For the September community advisory, for the September CHIP meeting here, we'll have that available. Is that right, John?
That's right, yep. And then just finally, one of the strategies is one of the health priorities is early childhood health, and on the regional community health improvement plan is a strategy. It's called Integrated Nurse Home Visiting Program, and what it does is it builds on existing home visiting programs provided by public health, and so public health offers programs such as Cocoon and Babies First, and these are home visiting programs where home visiting nurses goes out and supports mothers and young families, mothers and babies and young families around their health care. And so what this does is it integrates a mental health piece. And so during home visits, when risk factors are identified, the public health nurse reaches out to mental health and brings them into the program. And on the follow-up visit, the home visiting nurse introduces the mental health provider, and then the mental health provider goes in and does a follow-up program for 6 to 8 weeks. So there's a number of counties that have expressed interest in piloting this program over a one-year period, including Umatilla, Harney, Baker, Union, and Malheur. And
maybe Sherman.
And possibly recently Sherman. And so we're working on developing this program a little bit and reaching out to some funders to help provide this program. So the last thing I want to talk about is that, as you may know, Mira was the representative from this Community Advisory Council that sat on the Eastern Oregon Healthy Living Alliance board. So one person from each of the 12 counties is from, so we have, our board members consist of one person from each of the 12 community advisory councils of the EOCCO, and we ask that the community advisory councils that they nominate someone, and that name goes to our board, and we do a final approval around that. So we're looking for a nomination from this group to around a board member for the Eastern Oregon Healthy Living Alliance. So I know in the past,
John, just to be clear, it does not have to be a CAC member.
That's where I'm going. Yep,
Okay.
yep. So in the past, it's been the coordinator of this program, and that's worked out well. So as Paul was saying, this could be somebody from who is a community advisory council member, or it could be someone else from the community. I think ultimately we're looking for a diverse board. So certainly folks from the health community, but also folks maybe with an accounting background, legal background, folks from the business community. If they're connected to foundations and philanthropy, I'm certainly interested in connecting with those folks. And so just wanted to put